Hello, good evening everyone and welcome to the EUROGEN webinar series. Just before we get going, I'll take a couple of minutes just to explain a little bit more about what a European reference network is and does. So EUROGEN is one of 24 European reference networks created and funded by the European Commission since 2017, covering all different medical fields. And EUROGEN deals with patients with rare urorectogenital diseases and complex conditions. So they're all conditions where highly specialised surgery is needed. And it's really where that expertise is rare. And our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. And at the moment, we're currently 57 healthcare providers located in 20 member states. So I hope you saw from the slides at the beginning, one of the things that we do is we offer virtual consultations with members of the network, and this is completely free. And we use a special tool given to the ERNs by the European Commission, which is a safe and secure system that allows for cross-border virtual consultations called the Clinical Patient Management System. It's just been revamped. We have CPMS 2.0. So I really would encourage any of you who have a difficult case, please don't hesitate to get in touch. We'd really be delighted to test the new system with you. It's very easy and it's free. We do training and education activities together. We write clinical guidelines covering these rare and complex conditions in collaboration with the scientific societies wherever we can. And we have a EUROGEN patient registry. So that's very exciting. We hope that that will be fueling research and more evidence for the clinical guidelines going forward. So without further ado, this evening we've got a very hot topic, an update in the deferred management of urethral trauma. And it's an absolute honour, and we're delighted to have with us once again Assistant Professor Felix Campos-Juanatey, Marques de Valdecilla, University Hospital in Santander. Apologies if I pronounced that wrong at the end. And he's a consultant urological surgeon. His research interests are in urethral reconstruction and buccal morbidity after harvesting grafts. And we're really delighted that he's sharing his expertise with us this evening. This webinar is eligible for EACMA accreditation for live attendees who fill in the post-webinar survey. And it's also kindly supported by the ESPU as well, who we collaborate with. So thank you very much, Felix. It's an honour to have you here. You have the floor.
Thank you very much. Thank you very much for the invitation. Thank you for the introduction. And I will be starting now sharing the presentation. I hope you can see the presentation now. And without further delay, we're gonna start. These are my conflicts of interest. We are participating in a it's a non-profitable research project, which is funded by European Association of Urology Research Foundation, which is related with the dilatation of urethral strictures using the Optilum balloon. And I'm also a consultant for the company selling these Optilum balloons. We're gonna talk about that a little bit during the presentation. That's why I'm explaining my conflict of interest. And that's how we're gonna distribute our time. We're gonna stay around roughly about half hour covering all of these topics. And just to start, we're gonna start discussing or explaining which are the mechanisms creating the problem. And the problem in this case are strictures. And in order to explain that, first we need to start with the basis, and the basis are the anatomy. The urethral anatomy is different in the posterior urethra and the anterior urethra. I know all of you probably are familiar with that, and probably you're familiar as well with the distribution of the spongiosum tissue, which is different across the entire anterior urethra. And this is gonna have some implications for the treatments we're gonna have to apply for these patients. In the penile urethra, the main relationship with the urethra are the corpora cavernosa, and this is also involved in the trauma. So let me see if the video is working. In the penile urethra, it's not that common having this sort of trauma in the penis, because for the penile urethra being damaged, it's usually need to be stretched during erection. So are sort of uncommon, these sort of dog bites or even human bites, but the main reason or the main cause for strictures or for injuries in the penile urethra are penile fractures. And it is mentioned in the EIU guidelines related with urological trauma that we need to rule out during the evaluation of a patient with a penile fracture if the urethra is involved, because the urethral involvement is gonna have some implications for the initial treatment and also for the follow-up for these patients. And how often is the urethra damaged during the penile fracture? It is roughly about 10%. If you see this large series is around between 9% and 15% of the cases of the penile fracture are related with urethral involvement. And the treatment is immediate, so we need to be aware that in these cases we have to perform an immediate repair. These are some surgical pictures just to show you that urethra can be cleared partially, as you can see in the center of the image, or it can be a complete disruption of the urethra associated with the rupture of both corpora cavernosa. For sure, the involvement is more frequent when we have both corpora involved and when compared with a unilateral damage of one of the corpora cavernosa. And the treatment is, as I already mentioned, it's needed to be immediate, associated with the repair of the corpora cavernosa, and is usually an anastomotic repair of the urethra, spatulating both ends. If we move more proximally to the valvar area, we can see that the valvar segment lays below the pubic bone. So the main problem for the strictures in this area is, as you can see here, the fall stride injury. When you're just falling from the stairs, or just falling or having a kick in the perineum. And the other main reason is what is called the petrol tank injury, which is the one you can see in the top right side of the slide, when you have some sort of an injury in a motorbike or in a bike, and you're hitting the midline of the bike or the petrol tank on the motorbike. And as you can see in the image down below, the urethra get compressed down the pubic bone. So in these cases, it's anterior urethra. They are not associated with pelvic fracture in most of the cases. We're going to talk about that later, but you can see that the spongiosum is damaged, and there is usually some degree of fluid or some degree of blood accumulation in the perineal area, and probably in the scrotum as well, depending on the level of the damage. I'm going in the wrong way. And usually in this sort of blunt trauma, the management is in the acute setting, it needs to be conservative. So we are not going there for repair. We just put a suprapubic catheter, as you may see in the image. Or if there is a partial injury, we can try and make a gentle attempt to pass in a catheter transurethral. We can do if there is only a partial tear of the urethra, and we just leave this patient to rest. Leaving the patient to rest is probably one of the main messages of this webinar, because we need to keep these patients without further manipulation for the next 2 to 3 weeks, depending on the degree of the urethral injury. So we just keep the patient with the suprapubic or with urethral catheter, and we just have to wait for at least 2 to 3 weeks. And then we just have to perform a uretrogram. I'm going to talk about that later on during the presentation, in order to check that there is no problems, there is no leaks in the urethra, that the urethra is healed. And then the next message is that we need to keep these patients under close follow-up for the next months or even years, just in order to rule out any further problems. And these are particularly the problems we're going to deal in today's webinar. Moving to the posterior urethra, I already mentioned that the posterior urethra is not covered by spongy tissue, so the type of injuries is going to be slightly different. And you can see here the flow chart is different, because in the posterior urethra, it's not uncommon that these patients are unstable because of the sort of the trauma they have. The main reason for having injuries in the posterior urethra in our media is related with road traffic accidents, and they need, and if, of course, if the patient is unstable, we just have to put a suprapubic tube for the patient and just keep the patient alive with doing resuscitation or with doing any other sort of maneuver. On doing this sort of immediate endoscopic realignment, we just have the patient with the suprapubic, and we just have to wait for 3 months, and then we just have to deal with the stricture that is probably going to happen. So now, after this overview about the reason of the strictures, we're gonna see how we deal with the strictures. And I already mentioned that the management is gonna be different in the anterior one and in the posterior one. This is sort of the uncommon situation when we have a short stricture following a penile fracture in the anterior urethra. These patients probably usually have an injury. The injury was discovered during the repair, and it was repaired, but they come back with a stricture in the anastomotic side. And here is probably the only situation where we're going to be able to perform an anastomotic repair in the anterior urethra. And this is because it was demonstrated in this study that the outcomes in this sort of short stricture, less than 1 centimeter, following most of them trauma in the penis, most of them penile fractures, the outcomes are really good. But we need to take care that the stricture, they need to be short, because otherwise we're gonna end up with having some sort of cordy if we have to pull if we need to put a lot of tension in both ends of the stricture. Moving proximally to the valvar stricture, if we are lucky and the patients develop a stricture which is not completely we should perform at least one endoscopic approach. We definitely need to pass a guidewire, and we can choose performing dilatation, and we can choose performing uretrotomy. Probably keep the patient without problem for some time, and we should be tempted to repeat this sort of endoscopic maneuver because they are minimally invasive, but we need to make sure that we are not doing that so often. So because if we have to perform the dilatation, let's say every uretrotomy, probably we should think about performing a definitive treatment. And this was so until a couple of years that this product was released to the market, and this was validated to performing the dilation and releasing a coating of paclitaxel following the dilatation of the valvar segment. This is not specifically designed for treating post-traumatic strictures, and probably in the post-traumatic setting, if the fibrous tissue is too dense, probably it's not gonna work. But the good thing about this is also minimally invasive, so the patient, they're gonna usually going home following the procedure, so they can go home before moving the patient into theater to performing the urethroplasty. Because if the stricture is completely obliterative, or the patient have 2 repeated uretrotomies or 2 repeated dilatations, we should think about conducting an open repair. And the thing about the open repair, the reason about the open repair is because there are a lot of fibrous tissue. So our main problem, this is one of the main messages of the webinar, the main problem is related with the fibrous tissue at the level of the stricture in this sort of post-traumatic valvular strictures. So the recommendation is performing an end-to-end anastomosis, just cutting both ends and putting both ends together. I will show you later that the valvular stricture is some sort of distendable, so we shouldn't have problems in order to joining both ends together. Release the entire urethra circumferentially. We need to put some tension on the urethra. We just see using a scope or using a catheter or using a metal sound where the stricture is, and then we need to cut the stricture at the level of the stricture. You need to cut the urethra at the level of the stricture. We need to trim all the fibrous tissue in order to get both subtle ends, and we need to have both ends together that can be joined together. And in this stricture, you can see the amount of spongy tissue that is surrounding the urethra in the valvular segment here. And I think you can see my mouse. Here is the urethra, and all of this is spongy tissue that we have to trim in order to have healthy spongy tissue before putting both ends together. And this is how we're gonna see the anastomosis after performing the suture line, and I'm gonna show you in the posterior urethra that the technique is like that. You will have to spatulate both ends in separate ends, and we just conduct separate stitches. Usually, if the stricture is conducted in the proximal valvar area, where the most of the post-traumatic strictures are, we should perform two suture lines. One suture line in the dorsal segment and in the ventral side, and another suture line just in order to put together the spongy tissue. So I already mentioned that following the trauma, after 2 to 3 weeks, the urethra is healed. And the same principle applies after the repair. So following the urethroplasty, after 2 to 3 weeks, we need to conduct a uretrogram in order to see that there are no leaks. Because as you can see here, in some cases, there may be some, in the midline, there is a large defect, but in the other one, they can be small leaks. And it was proven that having large leaks at this moment is related with having problems of infection and having problems with recurrence of the stricture. So we need to conduct this sort of tests in order to improve our outcomes following the urethroplasty. And in order to conduct this test, we can do it in 3 ways. We can take the catheter out and we just do a regular retrograde uretrogram, which is one way. We can perform a pericatheter uretrogram, which is just putting like a small plastic catheter alongside the urethral catheter and just injecting contrast surrounding the Foley catheter in order to see if there is any leaks. And the third way is performing what is called a void to trial, which is just filling the urethra, filling the bladder with contrast through the bladder catheter, taking the catheter out and asking the patient to void, which is probably a better way, because we will see if the patient is able to pass urine at that moment. We're moving now to the posterior urethra, which are more common having the strictures in this area. And we need to make sure that we are not doing attempts of endoscopic approach if there is a complete obliteration of the urethra, as you can see here in this short clip. In these cases, if we don't have any sort of remaining lumen and we are not able to pass a guide wire, we shouldn't do any sort of attempt of cutting to the light or doing some sort of endoscopic maneuvers. And the reason you can see it clearly in this paper I'm mentioning, this group performed a systematic, they just conducting like a review of the MRIs of these patients before doing the repairs. And as you can see, in most of them, or in part of them, you can see the rectum that is filling the gap between both urethral ends. So if we're just cutting through the light, or we just cutting blindly in this end, we may end up in the rectum, or we may end up in the bladder, but not in the right way. So we can end up in the anterior side of the bladder and creating a foul passage, which gonna have more problems in the future. So that's the reason for not doing this sort of endoscopic approach for complete obliterations. Again, if we have some remaining lumen, we can perform an endoscopic approach. Again, we can do like here, we can pass a guidewire and we can perform a urethrotomy. We can perform dilations, but again, we shouldn't repeat these endoscopic maneuvers really often for the patient, because they haven't have benefits in the long term. So if the stricture is recurring every so often, we should think about putting the patient to perform an open repair, or referring the patient to a large volume, which is one of the messages of the next slide. This is another recommendation from our EIU guidelines in urethral stricture. This sort of posterior reconstruction of the urethra can be tricky. I'm going to show you later the maneuvers we need to should be able to conduct, and in these maneuvers, some of them are difficult to perform, so it should be only performed in dedicated centers in order to improve the outcome for these patients. And this is also one of the key messages of this sort of European networks of like the EUROGEN we are having today, the webinar, because these patients should be referred to someone else, or if not, at least you can have the ability to make a consultation with a large volume center, with a large volume surgeon, in order to see if this patient would be fit for a repair and could be transferred somewhere else in order to have this urethra fixed, particularly in the posterior urethra. And I'm gonna go over now the maneuvers that we have to perform in order to reconstruct the urethra. And my last point in this slide, and these patients, they can be transferred as well for performing redo surgeries. It was proven that if the patient is not willing to have a suprapubic tube for long term, or performing interval dilatation or whatever, having a second attempt or a redo procedure for performing an anastomosis, the outcomes are still fairly good in selected hands. So these patients are still having a good chance if we transfer the patient to a large volume or with experienced surgeons. So how to conduct this in the anterior urethra? We need to approach the urethra open. In order to place the patient, we need to discuss it with the anesthetist, and we have to perform it as we usually perform. I'm from the school in London, so we routinely perform the so-called social lithotomy or low lithotomy, which is the one you're seeing in the left-hand side. But other schools prefer, like the school in Chile or in the United States, they usually perform the so-called high lithotomy position, which is the one you're seeing in the middle of the imaging, which is high in the stirrups, really up, and putting the perineum nearly flat. And we need to be aware that we need to perform a midline perineal incision, like the one I already showed you for the anterior urethra, because the outcomes are better instead of performing an inverted U or even a lambda-shaped sort of perineal incision, because we're having less bleeding and we're having less damage to the perineal and to the scrotal nerves. The bases are the same. We don't have to locate the distal end of the stricture, which is fairly easy, just advancing through the meatus, a catheter or a scope, or even a metal sound. And you can see in the left-hand side, in the top part of the stricture, how we are cutting the urethra. But the tricky bit is locating the proximal bit. For locating the proximal bit, in some cases, there will be some amount of fibrous tissue between both ends, that I already showed you in the MRI. We routinely perform MRI for this sort of patients in order to prevent having any sort of troubles, and to make ourselves an idea about the length of the gap between both ends. And in order to locate the proximal stump, we need to advance The classical way is performing with a Clapton sound, with a hair growth sound, or with a Benike sound through the suprapubic area. We have to locate the bladder neck, and we need to make sure that we are advancing through, you can see in the lower image, but this can be tricky because we are doing it blindly. So we usually perform it with an endoscope. We just dilate the suprapubic catheter tract. We just put a scope through the bladder, and as you can see here, we need to see the verum montanum, and we need to see the proximal stump of the urethra, and you can see that we are feeling with our finger from the perineal area, and we can cut, if it's a disposable flexible scope, we can cut over the light through the scope, and if not, we can pass a needle in order to locate precisely where the urethra is, because I already mentioned when we are talking about the endoscopic realignment that if we are doing it blindly, we can create false passages, and we can even join the distal stump of the urethra with the anterior bladder neck if we're not finding the right place for the anastomosis. And then it's just a matter of performing a tension-free anastomosis. To performing a tension-free anastomosis, it's easy to say that because depending on the amount of urethra that is damaged during the trauma, and depending on how far up is the apex of the prostate, where usually the healthy proximal urethra is, we need to mobilize the urethra distally in order to join the urethra. But we need to consider that we shouldn't mobilize the valvar urethra more distal to the penoscrotal junction, because otherwise we will be compromising the vascularization of the valvar urethra, and also we will be compromising the erectile function of this patient, because if we put too much tension following the penoscrotal junction, again, we will end up with the patient having some degree of CORD following the procedure. So we need to make this so-called progressive perineal approach that was popularized by Wester and Ramon. And the first step is already mentioned. It's just separating the valvar urethra and separating it up to the level of the penoscrotal junction. The second maneuver is creating the plane between both corpora cavernosa. We usually conduct it using sharp with an scalpel, or if not, with some scissors, and we need to make sure we expose the dorsal vein of the penis between both crura of the penis. Once we see the dorsal vein, we need to distally ligate them, and proximally we can coagulate the proximal stump of the vein. And you can see there that the principle is just we need to straighten the urethra in order to make the distance between both ends shorter and make the tension-free anastomosis we are aiming for. The next step is performing an inferior pubectomy. As you can see in the diagram in the middle, in order to make a shorter way between both ends, we just have to trim the lower part of the pubic bone, and we usually do that just using the chisel and using the hammer, and then we just trimming the rest of the bone with the double angle bone nibbles. If this is not enough, which is weird because usually with these maneuvers, I will show you later on that most of the cases should be solved. The last step is conducting a urethral rerouting, which is just redirecting the valvar urethra posterior, usually to the right corpora, because most of us are right-handed surgeons. So what we have to do is create a passage below the right corpora, trimming a little bit more of bone in order to prevent compression between the corpora and the pubic bone, and just moving the urethra through there. And these are some pictures from one of our cases as well. And you can see in the first one, in the middle one, that we just passed the urethra there, and we are checking that there is no tension between both ends. And the second one is just when we're conducting the anastomosis, and you see in the very first part of the wound, both of the corpora cavernosa of the penis in front of us, and the urethra is below that, which is sort of really uncommon. And this was published a couple of years ago from a large Spanish group from one of the main universities in our country. And aside from publishing their experience, which is in the last row of this table, they just collected other larger series of posterior urethroplasties following trauma, and they just comparing their number of maneuvers they are doing in order to solve the stricture with the other groups. And you can see that all of them perform urethral mobilization up to the level of the penoscrotal junction, and then the more complex or more elaborated that is the posterior approach, the less common is. But the main problem is in some cases you cannot predict that preoperatively. Even if you conduct the MRI and you measure both ends, when you're doing the intraoperative evaluation, we need to see the qualities of the tissue, and in some cases you will end up trimming more urethra than you're expected to do. So you need to be prepared, or you need to know how to conduct all of these steps if necessary. And this is the last bit of the surgery, is just performing a parachute anastomosis. We just perform interrupted stricture as I showed you in the anterior bit, and with one of your assistants just putting the urethra slightly down in order to don't have problems with all of the trays you will have in your surgical field. It's just you have to parachute the urethra from the upper part to the lower one. We then perform a leak test. We just inject some lubricant or some saline through the urethra in order to see that there are no leaks in the anastomotic area, and we just pass the catheter at this moment. Again, we need to conduct a pericatheter ureterogram, usually between 2 to 3 weeks, depending on the quality of the anastomosis and the different approaches or the different steps we have to conduct. And if not, we just have to take the catheter. We have to take the catheter out. And just in the last 5 minutes, we're gonna review some new tendencies for this sort of repairs, particularly in the posterior urethra. I already mentioned that we have to wait for 3 months following the acute trauma in order to conduct the posterior repair, and the recommendation is a recommendation strong from our guidelines from the literature. But there is a group in Chile that is challenging this dogma, and they are just doing repairs with less than 3 months. They are usually performing it around 6 weeks following the trauma. And the reason is that we don't want the patient for 3 months with the suprapubic catheter, because the patients are really uncomfortable with the suprapubic. And they just demonstrate probably in a long short series of patients that the outcomes are completely comparable in all terms, having to wait more than 3 weeks with less than 6 weeks. And following this, or based on this, there is a recommendation that we can perform this sort of early repair, but if the patient is stable, of course. If the gap is not that long, the perineum is soft, so most of the hematoma is already dissolved or reabsorbed, and the patient is well enough or to put the patient in a lithotomy position, as I already mentioned, or the so-called social lithotomy or the high lithotomy. For instance, this group, they perform the high lithotomy position. So if the patient is able to do that, we don't have to wait for 3 months. And my second challenge is another dogma that I already mentioned during the presentation, that the main thing we have to do during these repairs is just taking the fibrous tissue out and just having to be able to join both healthy ends of the urethra, because we are considering that most of these patients are having, like in the bottom side, a trans having the spongy tissue completely affected, so a transmural affectation of the urethra. But it cannot be the case in some cases, because in some cases, particularly in the anterior urethra, the amount of fibrous tissue, probably it could be not that big as we are prepared to do that. So let me show you this quick video. This patient, I don't know why the video is showing like that, but this patient has a straddle injury, and we were prepared to conducting an end-to-end anastomosis, performing a complete section of the urethra, but we ended up with a really nice spongiosis, so without any sort of hourglass deformity in the spongiosis or any sort of caliber damage in the spongiosis. So we ended up performing a non-transecting anastomotic repair. But the problem is that we cannot predict that preoperatively, even if we have, like we do, a really nice group of radiologists can perform really nice ultrasound of the urethra. We cannot predict the amount of fibrous tissue, and even if it's with a complete reiteration, in some cases it may be worth it performing, like I'm showing here, and a repair. We should be able to trim as much as tissue, as much as fibrous tissue, like we're doing in a regular end-to-end anastomosis. But if we can preserve at least some amount of spongy tissue, is going to have some benefits. And it was proven in larger series. All of them, of course, are related with most of the patients having a stricture related with iatrogenic stricture, but we know for sure that the outcomes are comparable with the transecting group, and we're having better results in terms of the penile function, less problems with glands numbness, and less problems with the sensation of less feeling of the glands during the relationship. So it's worth it to think about that. And even in the posterior aspect of the urethra, we can try to perform as well a non-transecting approach. And actually, these images are from the original technique of the non-transecting. And if we can isolate the valvar arteries, and we can isolate the proximal valvar stricture, we can perform the anastomosis. And this was as well popularized by the Chilean group, that they discover, or they just propose conducting using a Doppler probe if both of the cavernosal arteries are preserved intraoperatively, and then preserving at least one of them in order to have less ischemia in the anastomosis. And the outcomes are this. It was just published a couple of months ago, and the outcomes are comparable in this sort of non-transecting approach for the posterior urethra compared with the transection, with the classical transection approach. And even if we are preserving the valvar arteries, we should be able as well to perform the elaborated approach in the anterior aspect. So we should be able to perform the separation of the crura. You should be able to perform the inferior pubectomy, and with this maneuver should be enough. We should be able to perform at least one of the valvar arteries for the sake of the patient. So just in order to conclude my talk, I just remember that we only have to perform the immediate repairs in the penile urethra when we have acute injuries related with trauma, or in penetrated injury, which are not common in our media. In the rest of the cases, we just have, if we can pass a catheter, we just have to wait for 3 weeks if the catheter is in order to see if that is healed. If we just put the suprapubic tube for a posterior urethra, we should be able to perform, to wait at least 6 to 3 months. I already discussed that during the presentation. If we are lucky, or the patient is lucky enough to have a non-obliterative stricture, and we are able to pass a guideway through the stricture, we can perform at least one attempt of endoscopic procedure, but we need to keep in mind that repeating these procedures endoscopically in the long term is probably not for the benefit of our patients. We need to remember that the failures following the open repair, most of them are related with not removing completely the fibrous tissue, and we need to keep that in mind during the urethroplasty, and we need to be some sort of aggressive removing the fibrous tissue and making clear that both ends join together without tension and without no remaining fibrous tissue around the urethra. And we need to think that in some cases, in some selected cases, we should be able, or we can perform a non-transecting approach in the anterior or in the posterior aspect of the urethra, and we can apply that for selected cases I already mentioned. So thank you very much for your attention, and hopefully we will have for some time now for questions.
Definitely. Thank you so much for your presentation. You can see the questions. I think you need to stop sharing for you to be able to see the questions.
Let me, exactly.
Right. So for the attendees, you can type in your questions in the questions field. Like I mentioned at the very beginning of this webinar, down below you have a question mark which says Q&A. So if you type in your question there, we will discuss it. I can see that 2 people have already passed some questions through.
Yeah, one of them is related with the recommendation of any book or any atlas for studying the techniques. These techniques are sort of a standard. And for instance, during the presentation, the presentation is recorded, so you should be able to see the presentation later on. There are a couple of reference of articles where this approach are explained, so we should be able to follow in that. And if not, there are a couple of books from probably the most renowned guys you should recall. One of them is called Art of Urethral Reconstruction from Guido Barbagli and Sanjay Kulkarni, which is somehow old. Another one is from the group of Brandes in the United States, and the most recent one is from Tobias Kohler and Francisco Martins from Lisbon, and it's also a really nice compilation of urethral stricture techniques. So with these books, you should be able to to get yourself prepared, at least in the theoretical part, for confronting these challenging cases. And we have another question from Arthur Lauriot, and probably forgot me if I didn't pronounce it properly. And question if we have any experience with the posterior urethral stricture in children. We don't do children in our institution. We will just starting operating on them when they are around 14, 16 years old, when they are probably most of them grow up. But the basis of the techniques are mostly the same, because what we have to do is just performing an anastomotic repair and removing most of the fibrous tissue. So the techniques should be applied for children are the same, but I cannot share my experience because we don't have that experience, because we don't do children in our institution. We have another question now. One of them is, what do you recommend for patients after pelvic radiotherapy with urethral trauma? That's a really good question, because you already know that adding the radiotherapy to the equation makes more problems, or at least more risk for the vascularization of the tissues. But it's just a matter of assessing this case individually, as I mentioned in the presentation. You should be able to discuss with the patient, and that you should be able to discuss with some of your more experienced colleagues the chances for this patient. So if you perform for them an MRI, and if you see the quality of the tissues, depending on the reason for the radiotherapy, if it's for a prostate cancer or for a rectal cancer, and if you see the distance of the gut, the amount of mobilization this urethra is going to need, probably you will have a meaningful discussion with the patient about the chances. And if you have to mobilize really farther up the stricture, and you have some sort of cavitation or some sort of nasty complication in the pelvic area, probably this patient is not a good candidate for having a perineal repair of the urethra, even if it's a traumatic urethra. And the second question is the use of stem cells and tissue engineering in cases of complication after urethral trauma. This is an interesting field, and there are some groups conducting really nice investigations about stem cells in these settings. I'm not sure, and they are probably not testing this in traumatic patients, because I think that I just stressed that during the presentation many times, that the principle for the strictures in this case are fibrous tissue. And if the fibrous tissue is just transmural, so if we don't have any sort of spongy tissue around, the stricture is going to come back because we don't have anything to be healed. So I'm not sure if the stem cells are going to heal well enough in order for these patients. But for strictures with less fibrous tissue or less spongiofibrosis, for instance, the strictures following iatrogenic injuries, there are some groups using stem cells just in different approaches. One of them, they are just injecting the stem cells. Another of them, they are putting the stem cells in sort of jelly around the catheter following urethrotomies or dilations. And regarding the tissue engineering, I don't think now there are any sort of major breakthrough that I can share with you. I think that in Germany, there are available some sort of performing a graft, an artificial graft of the mouth. So you just take a small bit of the inner part of the mouth, and the company just grow like a large layer of the oral mucosa, and then you can perform the urethroplasty using this artificial or the artificially grown oral mucosa. But the main problem with the tissue engineering is that you don't only need the oral mucosa or the urethral mucosa, because you only have to grow, and that's the main problem. You need to grow the submucosa. That is where most of the vascularization is gonna come for following the repair.
Yes, and we had a webinar, I believe last week or the week before that, with Professor Christopher Chappell.
Exactly. Yeah. I think it was last week, actually.
Yeah, I wasn't there myself, but you can find it on our YouTube channel if you're interested. It's all over there for the attendees. Let me see the other questions. I believe we were here. Do you have experience with Optilum for anterior urethral strictures? I think we were there.
Yep. There's another question about if we have experience with Optilum for anterior urethral stricture. And yes, we have a large experience with Optilum for urethral stricture. We performed more than, I think last time we checked, we were over 70 cases of anterior urethral stricture treated with Optilum. And the outcomes are fairly good, are comparable where they was published in the Robust trial. And we already published at the beginning of this year a multicentric study with our experience in Spain, in many centers, just in real world experience. And the bottom line of the study, if we stick to the indications, let's say less than 3 centimeters, valvar stricture, not too dense, and not completely obliterative, the outcomes are really good. But as soon as we start using it in posterior urethral, larger strictures or stricture with prior radiotherapy or with different settings, the outcomes are not that good as expected. And we have more questions. In proximal anterior urethral non-disrupting trauma with primary realignment with the transmitted catheter, how long will you leave the catheter? Exactly. So if we were able to pass the catheter during the acute setting, we just keep this catheter for 3 weeks if the patient is well enough following the trauma in these 3 weeks, and we conduct a retrograde ureterogram. We can perform it either pericatheter or just taking the catheter out, and putting some contrast inside of the urethra, or just filling the bladder with contrast and asking the patient to pee and see if the damaged area is healed. If it's not healed, then we need to leave the catheter longer. And probably I will repeat this pericatheter ureterogram, let's say in a weekly basis or in 10 days basis until it's completely healed. We have another question. Does 3 months urethral respirator is also suitable for post-wound shot? Exactly. Yes, the 3 months rule is usually because in these patients, we will have a lot of perineal hematoma, in some cases also scrotal hematoma, and we need for all of this hematoma to go away. So 3 months is usually the most recommended time. The gunshot urethral strictures, it's one of the situations where if the patient arrives to the emergency room in a place where we have a urethral surgeon, we should be able, or we should offer this patient an immediate repair, because for the penetrating injuries, we know that the immediate repair is also faring well. Okay, so if we can perform immediate repair, that's fine. If not, just put a suprapubic catheter and wait for 3 months. Another attendee is mentioning the mucosal. It is the layer of buccal mucosa that is proposed for using for the urethral repair. I think it's only available in Germany. And another question about the transurethral catheter in children, that I think we already covered that in our previous answer. And another question, if we use any sort of prosthesis for the repair, we don't have any prosthesis. So the endoluminal stents for the urethra are not faring really well. So then the initial metal stents that they were proposed for urethral strictures were a failure, most of them, so with a lot of problems. And the metal coated ones, it could be a temporal solution, but you need to be aware that they can be incrustated and they need to be repeatedly changed and interval times. So I don't advise using them, and I just leave the catheter following the procedure. And if the stricture is coming, just try to perform an open repair. There's another question that is probably completely out of the webinar topic, that is ioptilum good resolution for BPH patients. There is a new balloon, a new BPH balloon, optilum balloon, that is now sold in the United States, and I don't think it's still sold in Europe, but it's gonna come. It should be available, but it's different. It's a different type of balloon than the one used for the urethral stricture. So I don't think we should cover that in our webinar.
Great, thank you so much. I think that were all the questions, and we're perfectly on time as well. So at the end, I just want to mention that, again, this webinar has been recorded, like we've mentioned before during this webinar. I will be sending the links, the link to the YouTube video tomorrow to everyone who registered for the webinar. For the attendees who attended live, there will be a survey sent to you immediately after the session has finished. So if you would be so kind to fill that in, that will help us improve our sessions, but also you will get a EACME certificate within 2 weeks' time. So after 2 weeks, if you fill that in within two weeks' time, you will get a certificate after the 2 weeks. So yeah, it has been recorded. You can find all our past webinars on our website and YouTube channel, and we will have another webinar next week. So thank you so much for joining, and thank you, Felix, for presenting this webinar. It was very interesting. Thank you very much.